guys, my name is Binga-an, a fourth-year nursing student from Negros Oriental State University here in Dumaguete City.
Fluid and electrolyte imbalances as presented by acute tubular necrosis. An overview. Fluid and electrolyte balance is fundamental to the process of life. Abnormal fluid volume and electrolyte concentrations can seriously alter physiologic homeostasis and can be life-threatening. Although medical therapy to prevent and treat fluid and electrolyte disturbances is the physician's responsibility, nurses play a major role in all the aspects of patient care. Understanding how fluid and electrolyte disturbances occur and how the body compensates serves as a foundation for understanding many diseases and associated nursing management. Acute tubular necrosis, or ATN, is the most common cause of acute renal failure. Early recognition of patients who are at risk for ATN can prevent or improve the course of ATN. Acute renal failure is classified as pre-renal, intrinsic, or post-renal disease. ATN is classified as a type of intrinsic renal disease. The clinical course of ATN is divided into the renal failure phase, the diuretic phase, and recovery phase, with each phase having distinct symptoms and laboratory findings. Diagnosis of ATN often is complicated and confusing. Understanding of laboratory findings can facilitate the critical care nurse's ability to assess those at risk for ATN. The care and treatment of the patient with ATN is complicated, and specific treatments are discussed in detail. The critical care nurse play a vital role in identifying the patient at risk, preventing the development of ATN in those at risk, and providing appropriate care for those who develop ATN. Anatomy and physiology. Although many believe that the kidneys are located in the lower back, this is not their location. Instead, these small dark red organs with a kidney bean shape lie against the dorsal body with all wall in a retroperitoneal position, that is beneath the parietal peritoneum in the superior lumbar region. The kidneys extend from the T12 to the L13 vertebra, thus they receive some protection from the lower part of the rib cage. Because it is crowded by the liver, the right kidney is positioned slightly lower than the left. An adult kidney is about 12 centimeters long, 6 centimeters wide, and 3 centimeters thick, about the size of a large bar of soap. When a kidney is cut lengthwise, 3 distinct regions become apparent. The outer region, which is light in color, is the renal cortex. Deep to the cortex is a darker reddish-brown area, the renal medulla. The medulla has many basically triangular regions with a striped appearance, the renal or medullary pyramids. The broader base of each pyramid faces toward the cortex. Its tip, the apex, points toward the inner region of the kidney. The pyramids are separated by extensions of cortex-like tissue, the renal columns. Lateral to the hilum is a flat, basin-like cavity, the renal pelvis. As seen in this photo, the pelvis is continuous with the ureter leaving the hilum. Extensions of the pelvis, calyces, form cup-shaped areas that enclose the tips of the pyramids. The calyces collect urine, which continuously drains from the tips of the pyramids into the renal pelvis. Urine then flows from the pelvis into the ureter, which transports it to the bladder to temporary storage. Blood supply. The kidneys continuously cleanse the body and adjust to its composition, so it is not surprising that they have a very rich blood supply. Approximately 1/4 of the total blood supply of the body passes through the kidneys each minute. The arterial supply of each kidney is the renal artery. As the renal artery approaches the hilum, it divides into segmental arteries, each of which gives off several branches called interlobal arteries, which travel through the renal columns to reach the cortex. At the cortex-medulla conjunction, interlobar arteries give off the arcuate arteries, which curve over the medullary pyramids. Small cortical radiate arteries then branch off the arcuate arteries and run outward to supply the cortical tissue. Venous blood draining from the kidney flows through veins that trace the pathway of the arterial supply but in the reverse direction, cortical radiate veins to arcuate veins to interlobal veins to the renal vein which emerges from the kidney hilum. Note that there are no segmental veins. Next is the nephrons. Each kidney contains over 1 million tiny structures called nephrons. Nephrons are structural and functional units of the kidneys and as such are responsible for forming urine. Each nephron consists of two main structures, a glomerulus, which is a knot of capillaries, and a renal tubule. The closed end of the renal tubule is enlarged and cup-shaped and completely surrounds the glomerulus. This portion of the renal tubule is called the glomerular or Bowman's capsule. The inner visceral layer of the capsule is made of highly modified octopus-like cells called podocytes. Podocytes have long branching processes called foot processes that intertwine with one another and cling to glomerulus. Because openings, the so-called filtration slits, exist between their extensions, the podocytes form a porous or holy membrane around the glomerulus. The lumen surfaces, or the surface exposed to the filtrate of the tubule cells in the proximal convoluted tubules, are covered with dense microvilli, which increases their surface area tremendously. Most nephrons are called cortical nephrons because they are located almost entirely within the cortex. In a few cases, the nephrons are called juxtamedullary nephrons because they are situated close to the cortex-medulla junction and their loops of Henle deep into the medulla. The collecting ducts, each of which receives urine from many nephrons, run downward through the medullary pyramids, giving the pyramids a striped appearance. They deliver the final urine product into the calyces and renal pelvis. Each and every nephron is associated with two capillary beds, the glomerulus and the peritubular capillary bed. The glomerulus is both fed and drained by the arterioles. The afferent arteriole, which arises from a cortical radiate artery, is the feeder vessel, and the efferent arteriole receives blood that has passed through the glomerulus. The glomerulus, specialized for filtration, is like any other capillary bed in the entire body. Because it is both fed and drained by arterioles, which are high-resistant vessels, and because the afferent arteriole has a larger diameter than the efferent, blood pressure in the glomerular capillaries is much higher than in other capillary beds. This extremely high pressure forces fluid and solutes, or smaller than the proteins, out of the blood into the glomerular capsule. Most of this filtrate, probably 99%, is eventually reclaimed by the renal tubule cells and returned to the blood in the peritubular capillary beds. The second capillary bed, the peritubular capillaries, arises from the efferent arteriole that drains the glomerulus. Unlike the high-pressure glomerulus, these capillaries are low-pressure, porous vessels that are adapted for absorption instead of filtration. They cling closely to the whole length of renal tubule, where they are in an ideal position to receive solutes and water from the tubule cells as these substances are reabsorbed from the filtrate prelocating through the tubule. The peritubular capillaries ultimately drain into interlobal veins, leaving the cortex. Urine formation. Urine formation is a result of three processes: glomerular filtration, tubular reabsorption, and tubular secretion. Glomerular filtration is that the water and solutes smaller than proteins are forced through the capillary walls and pores of the glomerular capsule into the renal tubule. For tubular reabsorption, water, glucose, amino acids, and needed ions are transported out of the filtrate into the tubule cells and then enter the capillary blood. Tubular secretion, where hydrogen and potassium, creatinine, and drugs are removed from the peritubular blood and secreted by the tubule cells into the filtrate. Fluids. Approximately 60% of the weight of a typical adult consists of fluid, water, and electrolytes. Factors that influence the amount of body fluid are age, gender, and body fat. In general, younger people have a higher percentage of body fluid than older people, and men have proportionally more body fluid than women. People who are obese have less fluid than those who are thin, because fat cells contains little water. The skeleton also has a low water content. Muscle, skin, and blood have the highest amount of water. Body fluid is located in two fluid compartments: the intercellular space, fluid in the cells, and the extracellular space, fluid outside of the cells. Approximately 2/3 of body fluid is in the intracellular fluid compartment and is located primarily in the skeletal muscle mass. Approximately 1/3 is in the extracellular fluid or ECF compartment. Body fluid normally moves between the two major compartments or spaces in an effort to maintain equilibrium between the spaces. Loss of fluid from the body can disrupt this equilibrium. Sometimes fluid is not lost from the body, but it is unavailable for use by either the ICF or ECF. Loss of ECF into a space that does not contribute to equilibrium between the ICF and the ECF is referred to as a third space fluid shift, or third spacing for short. Electrolytes. Electrolytes in body fluids are active chemicals or cations that carry positive charges and anions that carry negative charges. The major cations in body fluid are sodium, potassium, calcium, magnesium, and hydrogen ions. The major anions are chloride, bicarbonate, phosphate, sulfate, and proteinate ions. These chemicals unite in varying combinations, therefore electrolyte concentration in the body is expressed in terms of milliequivalents per liter. Sodium ions, which are positively charged, far outnumber the other cations in the ECF. Because sodium concentration affects the overall concentration of the ECF, sodium is important in regulating the volume of body fluid. Retention of sodium is associated with fluid retention, and excessive loss of sodium is usually associated with decreased volume of body fluid. The major electrolytes in the ICF are potassium and phosphate. The ECF has a low concentration of potassium and can tolerate only small changes in potassium concentrations. Therefore, release of large stores of intracellular potassium, typically caused by trauma to the cells and tissues, can be extremely dangerous. The body expends a great deal of energy maintaining the high extracellular concentration of sodium and the high intracellular concentration of potassium. It does so by means of cell membrane pumps that exchange sodium and potassium ions. Normal movement of fluids through the capillary wall into the tissues depends on hydrostatic pressure, or the pressure exerted by the fluid on the walls of the blood vessel at both the arterial and venous ends of the vessel, and the osmotic pressure exerted by the protein of plasma. The direction of fluid movement depends on the differences in these two opposing forces, which are the hydrostatic versus the osmotic pressure. Clinical data and health history of the patient. Clinical data: name, BIR, date of birth May 2, 1980, age 40, address Magabuamlan, Negros Oriental, sex male, status married, religion Roman Catholic, nationality Filipino, contact person is EAR, phone number is educational level, college graduate, occupation unemployed, health insurance PhilHealth, date and time of checkup December 13, 2020, source and reliability 50% client, 30% chart, and 20% significant other, attending physician Dr. RJC, and final diagnosis is acute tubular necrosis. Health history. Chief complaint: on December 13, 2020, patient BIR was rushed to the hospital due to a gushing lacerated wound on his left wrist. History of present illness: 5 days prior to admission, patient's family left him. 2 days prior to admission, patient was seen problematic. 1 day prior to admission, patient was seen happily conversing with his neighbors. Current health status: patient health history: no known illness, no known food and drug allergies. Hospitalizations and surgery: has been hospitalized and undergone appendectomy. Serious illnesses: no history of serious injuries or fractures, no history of serious chronic illness. Immunizations: he cannot remember it. If when exactly he had an immunization. Allergies: patient has no food and drug allergies. Medications: no medications taken prior to admission. Travel: no recent travel outside of the Philippines. Pathophysiology. Predisposing factors: surgery, accidents or trauma, muscle damage, liver disease, stroke, and heart attack. Precipitating factors: we have self-inflicted trauma or wounds, and nephrotoxic drugs and lifestyle. In my patient's case, he attempted to commit suicide, so he sustained a lacerated wound which has a length of 21 mm, width of 3 mm, and depth of 2 mm. Nursing diagnosis for this would be impaired skin integrity and risk for infection. Medical treatment would be antibiotics, and for nursing management we have wound care. So for lacerated wound, it then proceeds to rupture of tissues and blood vessels, which will lead to hemorrhage. Then a decrease in intravascular volume, a decrease in circulating blood volume, which will lead to a decrease in pressure in venous circulation, then decrease of venous return, and then decrease preload, and then decrease cardiac output, and then hypotension. So hypotension would lead to a decreased perfusion to the organs. It will also trigger the hypothalamus, and the baroreceptors are activated. First, we discuss about the decreased tissue perfusion to the organs. So if there is a decreased tissue perfusion to the organs, for this part, I will only concentrate on the kidney, since my case is highly concentrated a lot on the kidney. So the kidney then triggers a compensatory mechanism when the decrease of GFR. So when there is a decrease of glomerular filtration rate, the juxtaglomerular apparatus secretes renin into the bloodstream, and then renin converts angiotensin 1 to angiotensin 2 by ACE, or angiotensin converting enzyme. Then the angiotensin 2 directly acts on the blood vessels and do vasoconstriction, and also it stimulates the release of aldosterone from adrenal cortex to increase sodium and water resorption, which also then increases blood volume, and all of this will lead to an increase in blood pressure. And now that is for the kidney's compensatory mechanism. Let's go to the hypothalamus mechanism of action to increase the blood pressure. So when there is hypotension, it triggers the hypothalamus, and patient. So when there is hypotension, it triggers the hypothalamus so that the patient will feel thirsty. And then the hypothalamus then stimulates the posterior pituitary gland and the anterior pituitary gland. For the posterior pituitary gland, it releases ADH, or antidiuretic hormone, and then it proceeds to the kidney for the collecting ducts to increase water resorption. I'm sorry if I forgot to put a line that connects this increased water resorption to increased blood pressure. Anyhow, the effect of this is to increase blood pressure. And another effect of ADH is that it binds to vascular smooth muscles to increase peripheral vasoconstriction, and then which also increase peripheral resistance to increase venous return. Also, as a result, it increases blood pressure. Now let's go to the anterior pituitary gland. When stimulated, it releases ACTH, and then the ACTH goes to adrenal medulla, and then the adrenal medulla releases cortisol, epinephrine, and norepinephrine. First is we go to the cortisol. Cortisol stimulates the liver for gluconeogenesis. Next is the epinephrine and norepinephrine. For epinephrine and norepinephrine, they goes to the blood vessels, the heart, and lungs. For the effect on the blood vessels, it produces vasoconstriction, and then peripheral vasoconstriction to increase peripheral resistance and to increase venous return to increase blood pressure. And then another effect of vasoconstriction is that constriction of veins and sinusoids. Then it affects the liver. Then the liver is then mobilizes the approximately 350 ml of stored blood to increase the blood pressure as well. And now let's go to the heart. I'm sorry for that. So the effect of epinephrine and norepinephrine to the heart is that it increases the heart rate and contractility, and then it also goes to increase the blood pressure by pumping, increased pumping of the blood. The next organ is the lungs. It is when it increases its respiratory rate to increase the O2 the oxygen delivery to the tissues and other organs. Next effect of hypotension is that it activates the baroreceptors. So then the baroreceptors then signals travels via the 9th and 10th cranial nerves, which are the glossopharyngeal and vagus nerve, and then it stimulates the medulla oblongata, which signals to remove sympathetic inhibition, which increases sympathetic stimulation, and it signals the adrenal glands to also release epinephrine and norepinephrine to increase the blood pressure. So let's go back. Since there is a laceration or lacerated wound, nociceptors in the skin and mucosa are stimulated. It converts painful stimulus to an electrochemical impulse, which are then carried from periphery to the spinal cord via the spino-reticular tract or SRT and spinothalamic tract or SCT. Let's go first to spinothalamic tract or SCT. So impulses are then carried to the thalamus, then to the cerebral cortex for interpretation of pain, then it goes to the thalamus again, back to the thalamus through midbrain and medulla, then to the dorsal horns of the spinal cord, which conducts nociceptive inhibitory impulses such as serotonin, norepinephrine, endorphins, and then for the suppression of pain. That is why the pain that was perceived by the patient was a pain scale of 8/10. Next is the spino-reticular tract. So the impulses are then carried to the spino-reticular tract and then into the brainstem and part of the thalamus, and which then activates autonomic and limbic system. This activation of the autonomic and limbic system dilates the pupil by the cranial nerve 3, and it also activates the release of epinephrine and norepinephrine to increase the blood pressure. So increased blood pressure then leads to increased tissue perfusion and oxygenation. So next question, the question is, was the injury treated? Could be yes or no. For my patient, it was not treated immediately. But let's say the patient was treated immediately. So there is a restoration of circulating blood volume, and it will lead to a good prognosis. But the patient wasn't able to be treated immediately, so the prolonged hemorrhage will lead to exhaustion of RAA mechanism, which again lead to hypotension. In this part, blood loss has reached approximately of 1,600 ml, which are classified as class 3. Then the nursing diagnosis for this would be fluid volume deficit, and medical care would be immediate fluid resuscitation, blood transfusion, dopamine, vitamin medication. The effect of hypotension is that if the mean arterial pressure is greater than 70 degrees mmHg, there is no constriction of the cerebral vessels. But if the mean arterial pressure reaches less than 70 mmHg, sympathetic stimulation happens, and then there is a constriction of the cerebral vessels, which will then lead to decreased blood flow to the brain and into the cerebral, which will then lead to cerebral hypoxia, and then there is a progressive loss of consciousness. In my patient's case, he was confused. So Nursing management would be keep a safe environment, always orient the patient to time, date, and place, and monitor the level of consciousness. So let's go back. So hypotension then leads to decreased blood flow to the afferent arteriole, which will then decreases net filtration pressure in the glomerulus, then leads to decrease in GFR, and this will lead to a decrease of oxygen, glucose, and other nutrients to the cells. Then leads to a decrease in O2, glucose, and other nutrients to the cells, which will lead to cellular hypoxia, and oxidative phosphorylation stops. Then there is altered cellular metabolism. Then cells switch from aerobic metabolism to anaerobic metabolism, then which the ATP are decreased. So a decrease in ATP will lead to a decrease in calcium pump function, which will then there is an increase intracellular calcium. Then there is an activation of lipid peroxidase, causing free radicals to steal electrons in the cell membranes, which will lead to cell injury. Also, ATP decreases in sodium-potassium pump function, which lead to increased intracellular sodium and water. This will lead to a decrease in circulatory volume and hydropic swelling. Also, increased intracellular fluid means there is an increase in extracellular potassium, and also there is a decrease in extracellular sodium. Increase in extracellular potassium is hyperkalemia, and decrease in extracellular sodium is hyponatremia. Another effect of ATP is that there is an increase in lactate production, which will lead to lactic acidosis, and lactic acidosis will lead to metabolic acidosis. And for metabolic acidosis, it also decreases oxygen affinity for hemoglobin, creating a decrease of O2 and glucose. Decrease of O2, glucose, and other nutrients to the cells, and then the cycle is repeated. Another effect of metabolic acidosis is that it increases extracellular potassium, which also would lead to hyperkalemia. So, cell injury. Then the epithelial cells die, and there is an altered kidney function, and cells slough off. For the altered kidney function, it has effects for the grievance of loss of the function for the patient if the patient is still alive. And then there is a decreased function in generating new bicarbonate, and another is that it has an ability to convert or activate vitamin D, and decrease in secretion functions. First is that there is a decrease in function of generating new bicarbonate, which will then lead to a decrease in binding of bicarbonate to hydrogen ions. And so if there is a decrease in binding, this will lead to an increase in hydrogen ions in the bloodstream, which as an effect, it becomes a metabolic acidosis. And increase in hydrogen ions in the bloodstream reduces the activity of the sodium, potassium, adenosine triphosphate ATPase pump, which will lead to a decrease in cellular uptake of potassium. Then there is arises of extracellular potassium, which again lead to hyperkalemia. So for hyperkalemia, the diagnostic test was basic metabolic panel test, and result was 6 milliequivalent per liter. And the ideal signs and symptoms would be nausea, vomiting, diarrhea, colic, paresthesia, muscle irritability, muscle weakness, and dysrhythmia. What my patient experienced was nausea, paresthesia, dysrhythmia, muscle weakness. The medical management for this would be calcium gluconate IV and K-Exolate with sorbitol. And then the nursing diagnosis would be electrolyte imbalance of hyperkalemia. Nursing management would be advise client to avoid salt substitutes high in potassium, continuous cardiac monitoring, and plan adequate rest periods. The complications would be flaccid paralysis, ventricular fibrillation, cardiac arrest, and anuria. Next is we have the metabolic acidosis. Diagnostic test done was ABG test or arterial blood gases. Then the pH is 7.1. The bicarbonate level is 19 milliequivalent per liter. And then the ideal signs and symptoms would be tachycardia, tachypnea, nausea, vomiting, headache, and or confusion, loss of appetite, fatigue, and weakness. What my patient experienced was that tachypnea of respiratory rate of 27 cycles per minute, tachycardia of 130 beats per minute, nausea, confusion, loss of appetite, and fatigue. Medical management would be sodium bicarbonate IV, and nursing management would be monitor for cardiac dysrhythmias, monitor apical and radial pulses, monitor ABGs, and other laboratory data. Complications would be Cosmos respirations, flushed, warm, dry skin, dysrhythmias, stupor, and coma. So another effect of altered kidney function would be an inability to convert or activate vitamin D, which will lead to a decrease in vitamin D in the system, and decrease in vitamin D will lead to a decreased calcium absorption in the GI tract, which will lead to hypocalcemia. So for hypocalcemia, the diagnostic test used was basic metabolic panel test, and the result was 7.7 milliequivalent per liter. The ideal signs and symptoms would be nausea, vomiting, diarrhea, tingling sensation, muscle spasm, dysrhythmia, osteoporosis, positive Trosu sign, and positive Schwastek sign. My patient experienced nausea, muscle spasm, paresthesia, positive Schwastek sign, and positive Trosu sign. And the medical management would be activated vitamin D or rocatrol and calcium gluconate. Nursing management would be electrolyte imbalance, hypocalcemia. Nursing management would be to remove environmental hazards and educate family about the risk for seizures. Encourage to ingest foods that are high in calcium. Then frequent monitoring of the intravenous site, since calcium solutions can cause tissue sloughing if infiltration occurs, and continuous cardiac monitoring. The complications would be fractures, convulsions, tetany, and cardiac arrest. So hypocalcemia, which the body the body will stimulates the secretion of PTH by the parathyroid gland, and the parathyroid gland stimulates bone catabolism, and then there is a release of calcium from bones to bloodstream, increasing serum calcium. But wait, after that, another effect of the increase of calcium is that it will bind to the phosphate, which wasn't excreted by the kidney. So there is first is, let's go here. When there is a decrease in excretory function of the kidney, there is an elevation of phosphate, magnesium, and potassium, increase of BUN, creatinine, and also water. Let's start with phosphate. Increase in phosphate would lead to hyperphosphatemia. So this in this area, phosphate and will then bind to calcium, which will form calcium phosphate. Then there is a deposition of calcium phosphate precipitate on the skin, soft tissue, cornea, viscera, and blood vessels, which my patient experienced itching. So it was basically on the skin. Under the skin, I mean. So for phosphate, the diagnostic test was basic metabolic panel test, and result was 5 milliequivalent per liter. Ideal signs and symptoms would be fatigue, shortness of breath, nausea, vomiting, anorexia, sleep disturbances. My patient experienced fatigue, anorexia, and nausea. Medical management would be aluminum-based phosphate binders. We have Amphogel and Alternagel. And nursing diagnosis would be electrolyte imbalance, hyperphosphatemia. Next is magnesium. An increased magnesium will lead to hypermagnesemia, and the diagnostic test done was basic metabolic panel test. The result shows a 2.7 milliequivalent per liter, and the ideal signs and symptoms would be drowsiness, confusion, muscle weakness, hyporeflexia, hypotension, flushing, increased PR interval, shortening of QT interval, T wave changes. My patient experienced confusion, muscle weakness, and flushing. Medical management would be calcium gluconate. Nursing diagnosis would be electrolyte imbalance, hypermagnesemia. Nursing management advise client to avoid food rich in magnesium. Another increased electrolyte is the increased in potassium. As I've already discussed it earlier. And another is that there is an increase in BUN and creatinine. I'm sorry, I forgot to put the diagnostic results of on this part. So increase in BUN and creatinine will lead to pericardial disturbances, GI disturbances, hematologic disturbances, and neuromuscular and neurologic disturbances. For pericardial disturbances, pericarditis as a response to increasing uremic toxins, then this will lead to pericardial effusion, then to cardiac tamponade. For GI disturbances, there is a uremic fetor, nausea, vomiting, mucosal ulceration. For advanced uremia, we have constipation. Patient experienced nausea, vomiting, and uremic fetor. Nursing management for this one would be histamine H2 blocker. We have cimetidine. And complication would be GI hemorrhage. For hematologic disturbances, the ideal signs and symptoms would be decreased platelet function, bleeding, hematoma, anemia, decreased in WBC, and my patient experienced anemia and decreased of WBC. Medical management would be erythropoietin or epoetin alpha and blood transfusion. Complications would be GI hemorrhage, pericardial hemorrhage, and increased susceptibility to infection. For neuromuscular and neurologic disturbances, we have ideal signs and symptoms would be fatigue, lethargy, irritability, decreased attention span, confusion, coma, and uremic seizures. Patient experience fatigue and confusion. So another effect of decreased in excretory function is that water accumulated, resulting to hypervolemia. With hypervolemia, nursing diagnosis would be fluid volume excess, and the signs and symptoms experienced by my patient was weight gain of 0.6 kilograms, hypertension of this is 170 to 100 mmHg, peripheral edema of +1 both feet, and tachycardia, heart rate of 130 bpm. Also, there is anorexia. I'm sorry, I forgot to there is pallor rather, not anorexia. So the medical management would be calcium channel blockers, loose loop diuretics, that we have furosemide, and dialysis. Nursing management, we assess weight daily, monitor of iron over every 2 to 4 hours, frequent assessment of vital signs every 2 to 4 hours. There is fluid restriction, sodium restriction, administration of prescribed diuretics, assess heart sounds for heart failure every 4 to 6 hours, then assess breath sounds every 4 to 8 hours, and assess CVP at least every 8 hours. So the effect of hypervolemia will lead to respiratory disturbances and delusional hyponatremia. For respiratory disturbances, we have patients' hyperventilation of RR of 27 cycles per minute. Pleural complications will be pleural edema, pleural effusion, pleural friction rot. And then another effect was delusional hyponatremia. The diagnostic test done was basic metabolic panel test, and result shows a level of 125 milliequivalent per liter of the sodium. The ideal signs and symptoms would be nausea and vomiting, headache, confusion, loss of energy, drowsiness and fatigue, restlessness and irritability, muscle weakness, spasms or cramps, and seizures. What my patient experienced was nausea, confusion, fatigue, and muscle weakness. Nursing diagnosis would be electrolyte imbalance, hyponatremia. Complications would be cerebral edema, respiratory arrest, and coma. Another effect of dying of the epithelial cells is that cells slough off. And then there is accumulation of cells in the tubules, which are brown granular cast. Then there is an obstruction to the tubules, which will result to an increased intraluminal pressure and tubular injury. For increased intraluminal pressure, it will result to a tubular back leak. So if tubular back leak happens, this will result the what do you call this? The electrolytes that are supposed to be excreted by the kidney into the urine will go back to the bloodstream, causing again hyperphosphatemia, hypermagnesemia, and hyperkalemia. The BUN and creatinine also levels also increases. Then there is also hypervolemia, which will then when tubular back leak happens, it will lead to a decrease of GFR, and the result would be an oliguria, or urine output of less than 30 ml per hour. So at this stage, before I forget, the diagnostic test to know the rate of GFR is a renal panel test, and the level of GFR is G3B, which is moderately to severely decreased. Carrying on, so there is oliguria, which has a urine output of less than 30 ml per hour. So at this point, was the patient's condition properly managed, or did the patient undergo surgery? And the nursing management, if the patient went surgery, was impaired skin integrity and risk for infection. Medical management given to this patient would be local anesthesia and acetaminophen for pain. So to answer that is it a yes or a no? For yes, which was exactly my patient was treated, there is a sufficient amount of basement membrane that are intact, and regeneration of epithelial cells occur, and this will result in increase in urine output, since the kidneys are now in a rehabilitation stage or recovery phase. So kidneys are now functioning, but even if the urine output increases, the BUN and creatinine levels at this stage still increases. So the nursing management for the urine output of greater than 4 to 5 liters per day is that fluid volume deficit, and my patient experienced a dry mucous membrane, poor skin turgor, weight loss of 0.9 kilograms. And nursing management would be elimination of fluid restriction, since since earlier we mentioned that there is a fluid restriction due to hypervolemia. Now the patient is experiencing hypovolemia, so we have to eliminate that nursing management. Then we replace it with fluid and electrolyte replacement, and the fluid we used on these conditions are crystalloid solutions. Then next is we have to assess for signs and symptoms of electrolyte losses and maintaining fluid and electrolyte balance. So the next would be if there are urine output of 45 liters per day, this happens for 1 to 2 days. And then the next thing would happen is that the diuretic phase may last for 1 to 2 weeks with gradually decreasing diuresis. Of course, it doesn't just abruptly stop the diuretic phase, right? So it has to be gradually decreasing. So this phase usually lasts 1 to 2 weeks. Then next is that there is a restoration of tubular function and concentrating mechanism of the kidneys. So returning to the concentration of urine, and then there is a return to normal kidney function. This happens usually 1 to 12 months. So if the patient didn't undergo surgery or the condition wasn't managed well, there would be a sufficient destruction of basement membrane. Then this will result to a few nephrons that would be remained. This will result to end-stage renal disease or ESRD. I mean, if ESRD, is it treated or no? So if yes, we have dialysis and kidney transplant. So this will result to good prognosis. But if the patient wasn't treated at all, this will result to multiple organ failure, as what would happen if other complications might have happened. If the patient wasn't treated on time, these complications will lead to multiple organ failure, and lastly, it will lead to the death of the patient. So that's it for my pathophysiology. For any other questions, contact my email at kr91.umali@gmail.com. That's all for my report, and thank you.
My darling, I love you, 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 I love you.